Thank you very much. And if Dr. Shah and Dr. Mena can join, and Dr. Daskalasis is on the Zoom. There he is. Excellent. So we open it up to the group, and Kays has the first question. Dr. Reitmeyer.
Thank you. Fantastic presentations all. My question is really for Dimitri. Can you hear me?
Yes, I can hear you.
Great. So really, your department has developed a model for integrated sexual health services in New York in the last few years. It's really been an inspiration for many of us in the country. You haven't really said very much about how you did this. How did you garner the support, the advocacy, the political will to do this? Because this was a significant investment that happened in New York. And is that something that you think could be expanded beyond or emulated beyond New York?
So I think we do. I'll start by saying that that this really began conceptually in the Bureau of Sexually Transmitted Infections many, many years ago. The notion of really creating more integrated sexual health services. The political and community will subsequently came in the form of the work that happened in New York State and then ultimately in New York City to come up with plans to end the epidemic of HIV in our jurisdiction. The community, as they requested that the governor really create a strategy, when that strategy was created, the city, through advocacy again, and our mayor's administration and our city council, gave a significant amount of funding to really the HIV effort. Then leadership within our department really decided that that the money should not stream all to HIV, but in fact, the front line of prevention from the perspective of our direct services were our sexual health clinics and our Bureau of STI. So a very significant amount of that funding streamed to the Bureau of STI with the goal of implementing those programs, the PEP, PrEP, and Jumpstart program. But deeper in that is the notion that we were going to change our sexual health clinics into what we're calling destination clinics. So rather than places of last resort, we wanted to make them places of first resort, that individuals would look at our clinics as a place that they would come to access care and services in a way that's more innovative and interesting and potentially lower threshold than other venues. So I think it is emulatable. I think it does require political will. And I do think that, again, it requires leveraging a lot of different resources. That energy to leverage was all-consuming for about a year. And so anything that happens on the local level to really break silos in funding and really acknowledge the importance of sexual health, both from and STD specifically, in the goal to end HIV and that those epidemics is important. So I mean, I say that in the hopes that as federal funding comes down for ending the epidemic of HIV, that those monies aren't siloed away from sexual health and STD.
Thank you. Dr. Boyer.
Yes, I thank you for your presentation. I wanted to know from either of any of our speakers, what is the role of school-based health clinics or centers in screening and treating adolescents in your states? And also, do you have any models of success? If not, what are some of the biggest challenges that you're confronting in that regard?
We do have school-based clinics, and also we have a nurse who can provide education to these people who staff them. But again, education is not provided per se about sexual health or sexually transmitted infections. Most of these actually come to seek care at our clinics, so that is the only opportunity that we have where we can provide some sort of education. And again, it all depends on BIS availability and those kind of priorities that we have. But again, the only education per se in the college school curriculum is abstinence-based. Nothing about sexuality or sexual health is.
Yeah, I mean, it's kind of the same thing in Mississippi. I mean, not every school has a school-based clinic, and they are also, limited in terms of what they can provide in terms of education because they are in the school. They are within the school. So they, for example, Mississippi by law, you can't do anything beyond comprehensive sex education, which means that you can talk about condoms, but you cannot demonstrate how condoms are used. And as again, most of the school districts choose to do abstinence only. So they're very, very limited in what school-based clinics can do. There's a lot of potential, to get them involved and to get them engaged in expanding and creating a culture of sexual health services. I mean, especially given the high rates of unwanted teen pregnancy that our states have.
As far as Nashville, right now the role, the education of our students is seen as far to be the role of the DIS. Like I said, we only have 5 DIS, but right now it's usually by invitation only that we can come in and educate the students, and usually it's the high schools that are inviting us in to educate the students, but I think that needs to be done at an earlier age. I mean, I was talking to my 9-year-old, and he already knows stuff I was surprised he knew, so definitely we do have school nurses. Again, they're not in all schools, but that is something we can look into as another source of educating the young.
I just want to add, we have more luck with actually African American colleges, but sometimes it's too late. By that time, people are already infected. But I think we've had more luck in testing at African American colleges and events than with schools.
So from my perspective, school-based health clinics are important. We do have some STI screening programs in those schools. I think one of the issues is that not every school has such a program, and services are inconsistent in terms of what's provided depending on who that school-based health clinic is organized by. So I think they do have a role, but I think that the sort of organizational structure makes it challenging to sort of roll out sort of citywide programs.
Thank you. Jeff Crowley?
Yeah, so 3 of our panelists are from the South, where we know there are lots of challenges, lots of STIs, but we also know that often the South is resistant to external pressure. And I'm wondering, when we think about writing a report, should we think about pushing or pulling, giving incentives and letting you do things, or should we think about making you do things? And it just leads me to wonder, how do we write a report in a way that's maximally received well by stakeholders in the South so they want to work with us? Do you have any advice for us or things not to do in a report so that people aren't turned off before we get started?
I would say when we, speak to private providers about coming in and talking to them, usually is like, oh, how much time do you need? We have limited time. So if there are interventions that we should be, having the private sector to do, they have to be simple, short, and incentives always help. Again, that goes back, I guess, to funding, but that's what I would say. Something that's realistic, if you're a private provider and having to see 30 patients a day, you don't have time to do a 10-step process. So just as you keep keep in mind, trying to keep it realistic and simple as far as.
I would say, that although, well, that is true, right? I think that a lot of the STD care that happens in the South happens within healthcare systems, under which there is significant, I think, federal oversight. That includes, federally qualified health centers. That includes STD clinics. That includes other organizations that may receive, some kind of federal funding. And there are ways, I think, that if you really try to enforce, or somehow connect the funding with certain, outcomes, performance outcomes, you may have, I think, a different kind of results. So I will leverage, excuse me, Dimitri, I think the funding and the fact that most of the South, most of the STD control activities in the South are really, largely funded, through the federal government, to really, demand, efficiency, demand, improve outcomes, and somehow demand the tracking, of the outcomes and the improvement of services they provide.
If you draw a parallel with ending the HIV epidemic, some of the things that have been suggested are not new. We've been advocating for that for years together. But right now, there's a political will to do that, and everyone seems to be buying in. I think we need to have a similar buy-in, for STIs also. Having experts from this panel, policy advisors, congressional delegations, everyone needs to understand, the seriousness of the situation, and at the same time also have buy-in from faith-based organization. Both of them, STIs and HIV, can go, run in parallel. Again, there are overlapping things. So we need to, again, try to have this addressed in the report.
Very good. Our last question will come from Ned Hook.
Dr. Mena, you mentioned that in Mississippi, abstinence-only educational efforts are still underway, despite a large body of evidence to show that it doesn't work. I'd be interested in what's going on in Tennessee and Arkansas regarding abstinence only, and in an era when we're trying to pursue evidence-based interventions. How do we counter that? Can you educate your political and governance bodies, or does this have to come through advocacy from the population in general?
The question is for me, okay. I
think it's for all of you, because I'm interested in what's going on regarding abstinence only in both Tennessee and Arkansas as well.
So in terms of, what do we do, right? I think that there are two things. There is a long-term strategy, which I think should come, a change of the cultural norms, and should come from advocacy. Really, parents, recognizing the need that there is, for the children to have really, evidence-based education, so they can really, navigate the challenges of their own sexuality. But in the short term, I think we really have to think about, kids, lack of education doesn't keep children from having sex, as we have known for many, many years. And I think that somehow us, have to think about how we can bypass all these, barriers to really, give access to these, children, emerging adults, to evidence-based education. And examples were presented this morning as the website of Watch. How can we really create a web-based or some kind of web-based, access to education, that can bypass the ineptitude, I think, of our governments to really, provide there in the appropriate settings. And that's kind of one of the things that I think we should do. We should consider at least doing.
As far as Tennessee, I can only speak for the local level. We usually start with, yes, abstinence is the only way to prevent sexually transmitted infections and pregnancy, but also explaining what is abstinence, excuse me, because people have different definitions of that as far as, the public, and then going on to explain as far as, doing a sexual transmitted infection education, because people are not abstaining from sex, be it whether they're 15 years old or 65 years old in a nursing home. So just we try to be realistic that sex is happening and just giving people the proper information so they can make wise choices.
So, Dr. Hook, it's the same issue with Arkansas too. Again, abstinence is the only form of education that's usually. Few years ago, we had over 600 school districts. We have merged, and now it's about 300. Going to 300 individual boards and trying to convince them that this is in the best interest of your children in the community is going to be a monumental task unless we have political buy-in. Which is very difficult in conservative southern states. The HIV thing is coming from the federal level, and there seems to be more buy-in for that. And I guess we should try to again, leverage maybe this along with HIV. The STDs also might be an opportune moment, unless we have from the grounds up advocacy folks. Telling their local legislators that this is needed, telling their school boards that this is needed. We need to have this, for the sake of our children and for their future. It's going to be a difficult task. And again, guidance from this committee about having, good school appropriate sexual health education is important.
All right. Well, we really appreciate the four of you. We know that you've taken out from either clinical duties or your public health duties, and we thank you for joining us and hope we can rely on you as resource persons as we go forward. So thanks very, very much.
Thank you.